Okay, I think we're about there, guys. There may be one or two more to come in, but if we can start, just to welcome you and thank you for joining us at this online public lecture. To ensure that our talks run smoothly, can we ask that all microphones remain muted and videos switched off? Talks will be recorded and subsequently will be made available online. Your screen name and video should you enable it, may appear in the recording. This will be an opportunity to ask questions at the end of the session. If you would like to ask a question, please raise your hand and our moderator will indicate when it's your turn to speak. Please unmute yourself and ask your question. You can find the raised hand option under the participants settings. It should be the first option that appears. I do hope you enjoy this talk and I'll pass you over to Vicky for her introductions.
Okay, we'll just switch the screens, and if Nick, you can just pop your presentation on, because I'll use your first slide and then we can check it's working as well.
It's showing for me now, Vicky. What have you got? Can you see?
Oh, I can't see it. Alison, can you see Nick's slide?
No, I can't see them either.
Right, I'll probably go back out and do what we did last time to get into it.
See you. Okay, so just whilst Nick's finding his presentation, the dress rehearsal went superbly, and now we've lost Nick's slides. I'll take the opportunity to just introduce Nick. I think we're getting there now. So I'd like to introduce Nick as being a visiting professor here at Loughborough University, as well as being the chairperson for the British Paralympic Association, as well as holding numerous other roles with the International Paralympic Committee, his own sports clinic. I think we've lost your slides again now, Nick.
We're there now.
Possibly there, yeah, we're there now. So I think the delegates have heard my brief introduction, but really what I would like to do is just welcome Nick to Loughborough University to contribute to our seminar series. This one dovetails health and wellbeing as well as sort of sports performance. Nick has been a key leader in sports medicine and Paralympic sport. I'm not really going to say too much more, Nick, because I think I've seen the start of your presentation. It's excellent, where you provide obviously the backdrop as well as more about yourself. It's been a pleasure working alongside you, Nick. I first met you in 1996, where many of us as people supporting the Paralympic athletes as well as the Paralympians themselves knocked on your door to work out why I won't perhaps go into what it was, but why it was green, because everyone had been drinking the blue Gatorade, I think it was, and we all had issues that we wanted to be solved with your sports medic experience. And that's the first time I really got to know you. But it's been a fantastic journey so far, and I really hope that the delegates on the line today enjoy your presentation.
Thank you, Vicky, and good evening, everyone. Good morning or good afternoon, wherever you are in the world. It's a great privilege for me to have some time to spend with you to talk about the evolution of Paralympic sports medicine. And as Vicky said, I've known her for nearly 25 years now. We've worked together over many projects, and it's a great privilege for me to be associated with the Loughborough University, and particularly the Peter Harrison Centre and all that it does. So I'm going to talk about the evolution. I think it's really important really to understand where we've come from, because if you don't know where you've come from, you can't really see more clearly the way forward. If we think back, it was 1948. This is some of the members of the 16-strong archery team that took place in a competition. There were 14 men and 2 women who took place in an archery competition on the opening day of the Olympic Games in 1948. And 72 years later, we've gone from those 16 people, and this was the opening ceremony in Rio with over 4,500 people and thousands of crowds and millions of people worldwide watching this on their screens. So how does a movement evolve from 16 people in a field in Stoke Mandeville to this massive sporting event which we celebrate every 4 years? This is a small video which I think I'd like you to see, because it really sets the scene, but also has a particular personal connection to me, which I'm going to talk about a little bit later. But let's watch it and see.
In 1944, a Jewish doctor who was a refugee from Nazi Germany started a new spinal injuries unit at Stoke Mandeville Hospital. At the time, patients were only expected to live for 2 years, so the idea was to make their remaining days as comfortable as possible. Ludwig Gutmann had other ideas about their life expectancy and insisted on managing treatment his way. His approach was controversial to many, but Gutmann single-handedly revolutionized the care of the paralyzed. He got patients off sedation and turned in bed every 2 hours to prevent infections. Next, he insisted they got up and moved around by taking part in craft and sporting activities. One of Gutmann's most inspired ideas was to get wheelchair patients playing competitive sport as a way of improving fitness, boosting self-esteem and restoring personal dignity. On the same day as the opening of the 1948 London Olympic Games, Dr. Gutmann organised a team from the Star and Garter home to compete in an archery demonstration, and it had a lasting impact. The 14 men and 2 women who took part that day became the first Paralympians. Gutmann organised a similar event every year, and in each successive year, the Games got bigger and better. In 1952, the first international event was held when a small team from the Netherlands came to compete. From this date, Popper, as he was endearingly known, referred to the Games as the Olympics of the Disabled.
How important are games like these to paraplegics?
Very important. See, from both the physical and psychological point of view, but the most important is from the point of the social reintegration of the paralyzed into society.
The 1960 event is widely thought of as the first Paralympic Games, being held overseas for the first time, just after the Olympics in Rome.
400 paralyzed men and women took part, representing 24 countries.
From this point on, an annual event was held at Stoke Mandeville, and in each Olympic year, the Games moved, in the hope that they would be held in the Olympic city.
Well, that's just extraordinary footage, isn't it? And we can see how the movement's grown from there's 24 countries participating in Rome up to Rio, when there were over 160 nations participating. But we're still not fully complete yet. If you think about it, there are still 22 countries that have a National Olympic Committee, but no National Paralympic Committee. And it's really important that we are inclusive worldwide, and we make sure that nations give opportunities for people with disabilities to compete on the world stage to help change that reintegration into society in their own nation. The number of athletes competing has also increased from that 400 in Rome to over 4,000 now competing, and that ceiling is largely limited by logistics in the villages. So there's extraordinary growth of the movement, but also it's evolved in terms of the diversity and inclusion of the different impairment types over that time. So initially, Gutmann started the spinal injuries unit in Stoke Mandeville, and it was initially only for people with spinal cord injury in 1960. But over time, different impairment types have been included. And this, from a medical perspective, has changed the challenge for the care of these athletes, because we have this wide range of different impairment types with their different medical issues that we need to consider in relation to illness and injury management. So here we have some images just showing the sort of extraordinary athletes that we have today in the wide variety of sports, but also this need for particular care in relation to their own impairments. So here I'm going to just slightly go into my own story to give you how my involvement occurred. So back in 1974, we were National Rugby 7-a-side Championships. This is me with the long hair here on the side, and it's growing slightly in lockdown here in the UK. May not reach that same level again. But I was mad on sport, all types of sport, rugby, football, skiing, ball, all sorts of sport. I was just passionate about sport. And I studied medicine and then went into the Royal Air Force as a medical officer, and was working on a station in East Anglia in the UK, working on this Phantom F4 squadron. And I was playing rugby for my station, and I had a spinal injury. And this is me in hospital shortly after that injury with my sister there, who was caring for me, on this striker frame, which every few hours they would put another board on top and then invert you to help prevent pressure sores. And so this was my introduction into spinal cord injury through my personal experience. And here is Stoke Mandeville. It's interesting seeing that video because this is the ward that I was on. It was very similar, or in fact the building was the same as it was in 1948. And here we are on this old-fashioned Nightingale ward, where you came in at one end with your new injury, and as you progressed, you moved down the ward until you were fit for discharge. But it was during this time that I was able to witness my first Stoke Mandeville games in the summer of 1981. And I'm enjoying a glass of wine here, watching it. As you may know, if you've been to one of those, there was always a beer tent, a drinks tent, and then you were able to watch the sport. And here we can see back in those days, the type of the wheelchair that was being used, the racing chair, back then in 1981. And after 9 months in Stoke Mandeville, being still a serving officer in the Royal Air Force, I was moved to RAF Headley Court, as it was then. It later became the Joint Services Rehabilitation Unit. And I spent 4 months there. And that journey, that patient experience, that pathway of observing the rehab process and how that can impact on an individual really inspired me when I started to go back into my own medical career. So I left the Air Force and I went into primary care initially, but this love of sport and this experience in the rehabilitation program inspired me to go to do the sports medicine diploma at the Royal London Hospital. And there, an amazing guy, Professor John King, who was the course director, he founded the first ever diploma course in sports medicine in the UK. And so many people have been through that course and gone on to great things in sports medicine. And John was my mentor over many years and sadly passed away a couple of years ago. But he was the guy that gave me the opportunity. And I attended this course full time in these lectures. And I just suddenly found what it was that I needed to do in my medical career. But also at the same time, a former RAF colleague, John Reynolds, was the chief medical officer at the Barcelona games for the British team. And he got me along to attend my first meeting with the BPA in 1992 and said, Nick, you know, look, you've had your experience and you know about rehab, why didn't you get involved with the BPA? And that was my introduction. And there was just a small group of us. There were about 5 of us who were regularly involved and would go along and volunteer and go along to training camps and so on. But what my year's course in sports and medicine at the London taught me is that the care that was being delivered to Olympic athletes could and should be delivered to Paralympians too. So how do we take medicine and rehabilitation, as it was largely seen back in those days, and convert that into sports medicine and elite athlete care? So there are many challenges. So I had this desire to apply the principle of sports medicine to the para-athlete, but the literature base was very limited. There was no funding, we were all volunteers, and there was just a small group of us with a limited experience who were desperate to try and do this. So the sports medicine approach is, you know, knowing your athletes, spending time with them, understanding their individual issues. And then from that, you can anticipate the potential problems, and then you can introduce prevention strategies so that they are fit to compete. So initially it was just firefighting. We'd turn up at training camps or competitions, we'd be hands-on, we'd do what we could, but then we'd go away again. There was no longitudinal interaction with these particular athletes, and we needed to change that. So I started thinking about what is it that we would need to make Paralympic sports medicine a specialty? What are the different components that we would require to be able to say, okay, we're now fully delivering what the needs of the para-athlete are? And this little jigsaw that I created is some of those elements. And I'm going to talk about how we've evolved and fitted and given colour to some of those pieces over the last 28 years. So you go to the literature to try and find information to help inform you about the sort of things that you need to understand, the risks you're going to face. And back in 1992, if you did a PubMed search then, you would find a very limited number of articles. And when you took out those that related to wheelchair physiology, actually there were a total of 9. So there were 9 articles in total in 1992 in the whole of the literature that related to issues around the medical care of an athlete with a disability. One of these was the report about the Games in 1976 in Toronto, and it was a very descriptive paper, but a useful marker in the literature. And then in 1984-85, there were a couple of good papers from Kathleen Curtis, and you will see here that the terminology of wheelchair sports medicine and wheelchair athletic injuries, because the majority of athletes in those times were coming from that spinal cord injured background, and it was only evolving into the other impairment groups. So this is where the major groupings were. And then Mike Ferrara from the US, who I met, he was heavily involved in the delivery of the Atlanta Games, was also publishing in this area, starting to describe some of the injury experience and starting to actually get some data down about injuries in this particular group of athletes. So here we are in the jigsaw, starting to give a little bit of color, a little bit of shading into the area, predominantly around spinal cord injury and this phenomenon known as wheelchair athletes. So I wrote this paper in American Journal of Sports Medicine about what you mean a wheelchair athlete, because I started to think that what we needed to do was get into the specificity of the sport and the impairment to really understand the risks that these athletes were going to face. Because if we think about it, this is fairly clearly an athlete. You can look at his physique. This is David Weir, a multiple Paralympian champion, London Marathon champion, who's in a wheelchair. So as a wheelchair athlete, you could say this is quite a good description. But if we look at these other images here, we can see that there's a variety of different sports, some being played in a wheelchair. So the guys playing table tennis are using their standard day chair to play their sport in, whereas the wheelchair rugby players are using a heavily adapted chair for their sport. And there are athletes who are taking part in other sports who use a wheelchair for their day-to-day life, but not for their sport participation. So are they all wheelchair athletes? And how does that term really help us in terms of injury and illness prevention and risk? So over my first kind of decade of involved with the British athletes, attending a number of games, I started to produce a few different papers. I produced the heat and acclimatization strategy for the team going to Atlanta in '96. I started writing a bit about the history and started also writing about the topic of autonomic dysreflexia or boosting in parasport. And I think that being this annoying physician from Great Britain who would keep asking questions of the IPC, they thought probably it might be easier to actually get him to join us. So by this time, by 2000, there was now this massive total of 35 articles in the whole of the literature. So we made some progress from 9 to 35, but it's really still a long way to go. And we started to fill in a few more of these little jigsaw pieces, a little bit of colour in some of them, but we're starting to create a bit more of a visible picture now. So in 2001, Michael Riding, the Chief Medical Officer for the IPC at the time on the left, and Tony Pascal, who's head of anti-doping, asked me to join the IPC Medical Committee. And there were just 5 of us then doing the whole work. In fact, we wrote the anti-doping code for the IPC. And it was just, again, we just all volunteers committed to a cause and trying to improve the welfare of athletes. So in that role then, we were going to the Salt Lake Games as the next game. And I said to them, if we really want to understand sports injury prevention and how we can reduce injury in parasports, we need to, first of all, establish the extent of the problem, the incidence and severity of injuries. And many of you will be familiar with, or should be familiar with, the Van Mechelen model of injury prevention. So you establish the extent of the problem, you then look at potential etiology and mechanism, you then introduce your preventive measure, and then you assess to see whether your intervention has been effective by repeating that cycle. And really there was nothing in the literature, so I decided we needed to do that. So we went to the Salt Lake Games, and I said to Mike, I said, I want to do an injury survey at the Games. And I enlisted the help of Stuart Willick, who was the polyclinic doctor in Salt Lake. And Stu said he would help me out in collecting the data. And every day I'd meet with him and we'd go over all the imaging of any athlete injuries. And we had a form, and we started pulling together, and we published the first paper in Medicine and Science, Sports and Exercise as a consequence of that survey. And interestingly, what we found that in the sport of ice sledge hockey, there were multiple lower limb fractures. And when you look at why that might be, at that time, there was no mandated leg protection for ice sledge hockey. And the sledges were all of different designs, and there was no requirement to have the height of the sledges at the same height. So you would get crossover. And also you had people who had had paralysis, who had osteoporotic limbs, sitting down on these sledges and then crashing into each other. So the consequence of that was multiple lower limb injuries. And you can see this rather shocking MRI of the knee of someone who had been T-boned by another player with his sledge. And I was just horrified by this and thought, what are going to be the long-term consequences of this? Although you may not be able to move the limb, if the leg gets stuck in a particular position, you know, it's going to cause problems with transfers and all sorts of things. So we needed to prevent it. So, sorry, just go back to this. So we went from there to the International Federation. We said, look, we've got an issue. We found these lower limb fractures in this sport. What if we made some regulations to look at the protective wear that was mandated? And what if you made some specifications where the height of the sledge had to be the same? And it was a fantastic interaction. The IF took on board our comments from this, and they changed the rules and regulations, much to their credit. But we moved on from Salt Lake to Athens, and the concern for Athens was twofold. One was going to be around the heat, and the other was around potential issues around pollution at the time. So the issues of heat and exercise are exactly the same for Paralympians as Olympians. That is, you can limit your performance and you are more likely to develop heat illness. But because of the specific nature of particular impairments, heat illness was much more likely to occur. So it was really important that we looked at mitigating factors. And this is when I got back together with Vicky again to do this study to see if we could look at athletes with tetraplegia performing in the heat. And there had been some work done on endurance exercise, but we felt that wheelchair tennis players doing repeated sprint movements across the court, or wheelchair rugby players, again, would be vulnerable. And so we wanted to look at cooling strategies that could improve their performance, because we felt that if we could get a message to athletes that this was about performance enhancement or mitigating a loss of performance due to the heat, we are much likely to get engagement than if we talked about illness. So we did this study where we had the athletes doing intermittent sprint exercise on an arm crank ergometer with 3 different conditions. So it was set at 30 degrees, 50% humidity, and we put them in the heat chamber. We had them doing this repeated arm crank, either without any cooling, or we pre-cooled them with an ice vest for a period before they went into the chamber, or we cooled them during exercise whilst they were in the chamber. And you can see the top black line with the squares is the control, where the core temperature, which was measured used with an ingested pill, over that time rose most significantly and reached 38 degrees within about 16 or 17 sprints. If we cooled them before they went into the chamber, which is the blue line, you can see we lowered the core temperature, and that the slope of the line is the same as the black one. So we delayed the rise in temperature, but it was at the same rate. But if we cooled them during exercise, we were able to alter the slope of that line so they could continue to exercise for longer. And here you can see the time to exhaustion in terms of the number of sprints completed and how we're able to change that relative to the controls, which then made us think about the different intervention strategies you could use in different sports, because they would each be different. It may not be appropriate to do cooling during the event, but pre-cooling might be. And then how do you logistically do that? What materials do you use? How do you do it practically? And from there, I also worked with other colleagues at my university and done further work on this area. And Dr. Neil Maxwell, who's in the top right-hand corner, is currently involved in producing heat countermeasures information for athletes going to Tokyo. So Athens, in terms of the heat, that was fairly successful. But in going back to the injury survey, we tried to repeat what we did in Salt Lake there. But in Salt Lake, there were about 450 athletes, and in Athens, nearly 4,000. There, I didn't have the degree of support. There was one radiologist who would come in intermittently to the polyclinic to do the imaging and reporting. And it was just nowhere near the same level of support that we had in Salt Lake. And as a consequence of that, unfortunately, that survey failed. And I think I take from that is that just because you failed, it doesn't mean to say you can't, don't give up. Failure is part of the learning process. And we moved on to Torino and Vancouver. The injury survey at Winter Games was now progressing, and we're involving some great researchers and assistants from Dr. Carolyn Emery from Calgary and Anne Allen from the US, North Carolina, joined on board, and we're able to produce further papers on injuries at the Winter Paralympic Games. And we come back now to that Van Mechelen model of injury prevention. We've kind of established some of the issues in relation to the particular sport, the frequency and severity of injury. We've postulated what the mechanism is for that. We've persuaded the International Federation to change the regulation, so that's our intervention, and then we're re-measuring it. And at the Games 2006 and 2010, there were no lower limb fractures during those games. So this is part of this continuous circle of prevention and monitoring. The next important step really was London 2012, and I was involved with the bid phase of London 2012, working from 2003 to present to the IOC bid committee. And an important thing in the UK was that we did not have a formally recognised specialty of sport and exercise medicine at that time. But we persuaded the Minister for Sport that it would be critical to our bid to be able to say to the IOC that as a consequence of hosting the Games, this specialty would be developed and there would be doctors who would be trained through that, who would be serving at the Games. And the day before we presented, we had this nod from the Minister for Sport that an Act of Parliament was passed to create the specialty of sport and exercise medicine. But my role in that was also to ensure that the aspects of sport and disability were included within the curriculum for all doctors going through that training program. So as we moved on to London 2012 from an IPC perspective, we've now got this much broader team of people who are coming together to try and really help deliver it. Beijing, we did not attempt it, partly because of the language issues in relation to transferring the information within written Chinese to information that we could use. So we decided that was not a good one to go to. But London 2012, I was acting as CMO for the British team, but involved with the IPC Medical Committee. And this time we looked not only at injuries, but illnesses as well. I need to recognise Professor Wayne Durbin and Martin Schwellnus, who were both at that time at Cape Town, UCT Cape Town, and Sherry Blauert from Boston. And they were fantastic colleagues. Martin and Wayne run the IOC Research Centre in Cape Town at that time and have a lot of experience in this area. And being surrounded by colleagues who are dedicated and experienced was critical to the support, to making this a success. But also having the support of the IPC was critical too. And Peter van der Vliet, who was the medical and scientific director over this period of time, fully embraced what we were doing and supported this financially as well as figuratively. As a consequence of that, we're able to produce a number of publications about the epidemiology of injuries at the London 2012 Games, and also about illness and the methodology for which we did that. And these were published in the British Journal of Sport and Exercise Medicine. So these big studies allowed us to look at the big picture of what was happening. And that's really critical, that thinking that Van Mechelen model about what's happening in terms of the injury incidence and severity, because that then allows you to focus in on the detail bit afterwards. But without that big picture, you can't progress onwards. So we think about our injury winter surveys. We've now done 5 of those. And just to come back to the ice sledge hockey, there has been one lower limb fracture which occurred in Pyeongchang in 2018 since those 5 that we had in Salt Lake. So that's been a great success, but I'm going to talk a bit more about our other work in alpine skiing a little bit later. But the injury and illness surveys, okay, we're 2 down and hoping to be there in Tokyo next year. So let's have a little dig into what that data's told us. If we look at injury rate by sport, we can see on the left-hand side the number of injuries per 1,000 athlete days. And there's an overall of about 13 injuries per 1,000 athlete days. And we can then stratify sports by risk, by their frequency of injuries. And when we look at that, we can see that football 5-a-side tops the table in terms of injury risk. And so, as I say, looking at that big picture allows us to see where the majority of injuries are and where we need to focus further work. As general risk factors, we see that Paralympians tend to be older than Olympians. The comorbidities from medical conditions are important considerations, and that manual wheelchair use is an independent risk factor for upper limb injury. But in terms of illness, what we see is that skin and subcutaneous tissue injury and genitourinary tract infection are significant factors in the illness which is not present in the Olympic athlete. And if we compare the illness rate or illness proportion between Olympians and Paralympians, you will see whether it's summer or winter, there's approximately twice the illness rate in Paralympians than Olympians. And so, although there are just over twice the number of Olympians at a game, there's usually around 10,000 and about 4,500 Paralympians, the workload for the medical team will be fairly similar in terms of the number of encounters. And where do those illnesses occur, in which impairment classes? And we see that the skin and subcutaneous illnesses tend to occur in the spinal cord injured, where there's insensate areas of skin, and those with amputation or limb deficiency. And the urinary tract infection predominantly in those with spinal cord injury and in neuropathic bladder. So these are things that you could probably anticipate, but we need to confirm these in terms of the strategies that we're going to use for prevention. When we think about the skin and subcutaneous tissue in the amputee athlete, you can see the residual limb. On the left, you can see the skin of an athlete where it's become sweaty, the pores have become blocked, and then this infection is starting to set in. And other than in the sport participation, there are important risk factors in relation to being in a Paralympic village environment than opposed to being at a World Championships or training at home. When you think about the Paralympic village, you've got the distance from your accommodation to the dining hall and back to the transport mile and back and so on. And this has a significant impact on the amount of steps undertaken. And this study by Brendan Burkett from Australia showed that on average, there was an additional 5,500 steps per day at a Paralympic Games. And it's this rate of increase, an 83% increase over the normal day, which puts this attrition on the skin and leaves it open to breaking down. So that means you need to think about the strategy you're going to use within village about getting people about, and maybe using alternative methods or bikes or other forms of transport to reduce the load on the ambulant lower limb. In terms of urinary tract infection, it's the commonest cause of sudden disabling infection in spinal cord injured athletes. You go from being well 1 minute to really unwell with rigors and a raging temperature the next minute. And this is something I know from personal experience, and have been hospitalized on several occasions over the last 40 years of my spinal cord injury. And so we need important education about hydration and hand hygiene, because when you're pushing around in your chair, okay, it's really important to encourage athletes to be really careful about hand hygiene when intermittent self-catheterization is used. So let's focus on a few areas now in terms of injury. And I'm going to talk about mechanics of injury, and we talk a bit about head injury and concussion in parasport, and the other important area of upper limb injuries. So those of you who know Ivan Landvik from Leuven, who was chair of the IPC Sports Science Committee for many years, he will tell you that biomechanics is everything. He's a biomechanist, but in relation to injury, he's absolutely right, because it's the injury is related to the mechanics of the sport. What forces you put on tissue and how you put it on, and the speed of application and all these things will determine the injury that occurs. So when you want to determine which structures will be damaged and how to prevent it, you need to understand the sport, you need to understand the impairment type, and particularly in relation to spinal cord injury, the impairment level, and understanding the biomechanical differences, because the push technique with one change in level of cervical spinal injury will make a big difference to how that athlete will push the chair. And different sports have different chairs with different uses. So we can't assume that everyone using a chair will have the same type of injury. So we've got a wheelchair racer who's pushing a very narrow push rim with the gloved hand here in 100 meters. And then you've got a tetraplegic wheelchair tennis player who's got his racket taped to his hand, who's going to have to push the chair with that taped hand. So the mechanics are not the same. Wheelchair basketball, again, different levels. We've got people with lower limb amputation competing and sit down in a chair and will have different degrees of trunk control than someone who's got a paraplegia, for example. And then wheelchair rugby, again, the weight of the chair, the shape of the chair, the angling of the wheels, all these things will impact on the forces that are applied to the tissues and potentially the different loads which occur, and therefore the potential injuries that can result. So let's go back to that London data. So football 5 had the highest incidence of injury in London, but also in Rio. So for 2 consecutive games, it's top the table for injury. So important to look at why that might be. I'm just going to play this little video, and if you have a look, there'll be a little collision in a second.
Strong block by Erkan, who was right in the way. There was a clash of heads as Nonato
These athletes
went to take the shot.
who are either visually impaired or vision absent,
both men are in need of
will
treatment.
be wearing an eye shade to completely obscure any vision that they do have. Now, when the ball is moving with the sound system in it, if the player is moving towards the ball, they should call voy or I'm going to indicate to other players that someone is moving in the direction of the ball. Now, if they don't call that or they delay in calling it, the opponent doesn't know that that person is in their proximity, and that increases the likelihood of them coming together. And as you can see from that clip, 2 people coming together and clashing heads causes problems. And what we found that the majority of injuries in football 5 are contacts with other athletes. And 5 out of 8 were reported relating to foul play. And if you don't call voy when you're moving towards the ball, that is technically a foul in football. So we need to do a variety of things there to think about how we minimize those contact injuries. So one could be better application of the laws that exist. So referees calling people out earlier and making sure that they do that. And the other is to think about how we might introduce some head protection. So if we're going to introduce some form of head protection, we need to understand the forces that are involved when those 2 heads collide. So we started doing some work with the British blind football team using these little sensors which they were putting onto the headbands of their eye shades. And so we could start to look at the forces that are involved. And not only can we see what sort of forces are involved, but also where those impacts occur. Because if you know the force and you know where it's coming to, you can then start to think about how you might design a protective piece of equipment that perhaps would include the eye shade and some form of protective wear. Furthermore, you need to think about the sort of materials that you utilize to make that protective wear. So we can think about its use for multiple purposes. So it could also be protective, the eye shade, but also perhaps a cooling mechanism. Could you immerse that in ice cold water before you play, so on a hot day you get cooling, head protection and the eye shade at the same time. Now this material illustrated here is called D3O, and it is soft and flexible, but when a force is applied it changes its properties. So the molecules lock together and it dissipates impact energy and reduces transmitted force. And this sort of material is used in military purposes, in motorcycle wear, in alpine skiing. And so if we choose the right material and know the sort of forces involved, possibly we can then design something that would be useful in reducing the risk of concussion in this particular sport. So on the right is my colleague Jamie Kissick from Canada. Jamie is the chair of the IPC Medical Committee, and I'm currently standing in for him because sadly he's having undergo some medical treatment at the present time. But Jamie is hugely experienced in ice hockey, able body and para, and a variety of sports where concussion is an issue. And together we wrote this paper about trying to highlight the issues that relate to parasports. I want to play you this video because when we think of concussion, we don't tend to think of athletics as a risk factor for concussion as a sport. So let's have a little look at this pile-up. So we get the head-on view, and there's an athlete slightly to the left with a white shirt who's just getting knocked over now, and we watch his head come down and hit the track there. And we've seen this happen multiple times in wheelchair track athletics. And typically it's been on that last bend when they're all jostling for position to come into the final straight, and there'll be a clipping of one chair against another, and this then causes this mass pile-up. And the picture on the right was taken from London 2017 World Athletics Championships, where we had 2 concussions in that particular pile-up. So what we started to do is put this concussion risk rating based on the sport, the impairment type, the collision potential, the impact speed, and whether head protection was worn or not. And it was our best guess, if you like, for the present time, something as a baseline to work from. And over this summer, COVID did many things, but it didn't stop us meeting. We were due to meet in person in June, but we got together virtually and formed a concussion in parasport group. And we've recently submitted a consensus statement about the issues for concussion in parasport. And that's currently under review at the present time. And what we've also done is started a Delphi study to look at how the standard concussion assessment as currently put forward, called the SCAT-5, might need to be amended for different impairment types. And we hope to present that in the literature and also at the Paris Consensus Conference on Concussion in October next year. Let's move on to upper limb injury. And I think this is a great slide because you've got this, this guy in his chair who's talking to someone and completely oblivious to the fact he's running over the arm of one of his own teammates. So upper limb injury in the wheelchair-dependent athlete is really important in terms of prevention because the upper limb is so important for activities of daily living, for propulsion, from transferring from chair to bed to toilet to car, for self-care, for driving. So for maintaining your independence in the long term, we're so dependent upon good function in the upper limb. So we know from able-bodied sports that the upper limb in overhead sports like swimming and tennis, these are risk factors. So the overhead activity. But let's have a look at overall in relation to para-athletes and the data we have. We see that the shoulder, the wrist, the hand, and the elbow are the 3 areas of injury that have the highest, 3 body parts have the highest injury rate in our data at Paralympic Games. And it's impairment and event specific. If you look at ambulant athletes, it's the thigh, the knee, the lumbar spine, the lower leg of the foot. And a wheelchair seated athlete, it's the shoulder, the clavicle, the elbow, the knee, the upper arm, and the wrist. So it's really important to get into the specifics of your injury surveillance dividing up athletics into these subcategories, because athletics is really multiple sports wrapped up under one name. So we think about wheelchair track athletes and look at their incidence of injury, and we plot that on here. Actually, it's relatively low. And that's because the action of pushing the chair does not involve the abduction of the shoulder above 90 degrees. And so the impact on the rotator cuff is much less. But if we look at field athletes, it's very different. So this is injuries in wheelchair athletics by event type. So these are people who participate in athletic events in a wheelchair. And what we can see from this is that it's the throwing event athletes who have the majority of injuries. And not only do they have the majority of them, but these result in a greater degree of time loss from competition. So if we plot wheelchair field athletes on this same graph, we separate them out, we can see what a greater impact it is. So that's why I'm so fixated on this issue of specificity of analysis of data in relation to impairment type and sport and event. So if you look at the top 5 injuries by anatomical region in wheelchair athletes, we can see it's this problem here, the problem of the throwing athlete. So as a consequence of that, we were more interested in understanding how do we assess that. And we did a study which is currently awaiting publication, where we compared 3 different elements: the subjective sensation of athletes in terms of shoulder pain, what the clinician sees on physical examination, and thirdly, what the ultrasound assessment of the tissue of the rotator cuff shows on those particular athletes. And we've done that at the World Athletics Championships in London, we've done it at the European Championships in Berlin, and also done it in powerlifting, where shoulder pain is a big issue. And this is with my colleague Dylan Morrissey from Queen Mary University in London. Now, please don't share this slide at the moment. Again, this is under review. But essentially what it shows, whether you're looking at track, field or powerlifting, that there is a good association between the WSPI, which is the wheelchair user's shoulder pain index, and the physical examination of the shoulder score, the PES, but very poor correlation with the ultrasound findings between the symptoms, the WSPI, or the physical exam. So physical examination and symptoms correlate well together across the 3 sports, but the ultrasound findings are not well related to either of those. And this is important when we think about this maxim of treat the patient and not the scan, because often we can start to do ultrasound scans on people and tell patients that they're going to have this, that and the other, but actually it has very little correlation to what they're feeling or the physical findings. So this is work in progress and should be out hopefully in the near future. So I also want to talk a little bit about boosting in Paralympic sport, because this is an issue which came up first in 1994 in the World Athletics Championships in Berlin, which was my first major event, where they suddenly said boosting in parasport is a doping offence, and that you could be eliminated from competition being found guilty of a doping offence. And me as a new team physician in said, well, how are you going to tell whether someone is boosting or not, particularly during a race? And how would you know that it's intentional rather than unintentional, that it's just happening spontaneously, as it can happen to anyone with a spinal cord injury of T6 and above? So I moaned a lot over several years, and it we managed to change it from being a doping offence to something that was not healthy. It was a health issue. It was unhealthy to compete in a dysreflexic state. And initially, this was determined by a blood pressure measurement prior to competition, which was set at 180 millimeters of mercury. And that was a very high level, really, for someone with a spinal cord injury whose normal resting blood pressure would be in the range of 90 to 100 systolic. But we needed to use some form of evidence to defend it from a legal perspective, and 180 was the limit advised by the American College of Sports Medicine for exercise testing. So that's how that figure first came about. For those of you who are not familiar with this particular phenomenon, people with a spinal cord injury around T6 and above have this block to their autonomic nervous system. And any form of painful stimulus below the level of the lesion causes this massive sympathetic response, which causes a rise in blood pressure and a reduction in heart rate, which can have a catastrophic effect and has caused death in people from stroke and myocardial infarction. We did a survey at the Beijing Games about athletes' attitude to boosting, and 40% of athletes who were susceptible by the nature of their impairment were unaware of it, but 17% of athletes questioned admitted to using boosting during training and or competition. So almost 1 in 5 athletes in Beijing who could be dysreflexic admitted to using it during training and competition. So we introduced this boosting testing program, and we've been measuring blood pressures in the core room in athletics. This is a picture I took in Swansea at the European Championships, and have collated that data over a period of years. And what that showed was that there was a fairly linear rise, but apart from a small group of athletes, this was a number of about 6 athletes, where there was this sudden rise in blood pressure, and they were competing with these blood pressures in, of almost 180, but never just above the threshold. So there appeared to be a number of people who were kind of manipulating their blood pressures to fall under the threshold. So as a consequence of this data, we made a recommendation to the IPC that they reduce the value for the hazardous dysreflexic state down to 160. And remarkably, in Rio, those athletes who had been up at 180 suddenly had managed to have lower blood pressures. So the policy seems to be having a deterrent effect, but we still seem to need to do further work on this to establish what the level should be. So let's think about my original desire to give para-athletes the same care as Olympians. And I just want to take you through some of the work we did in London 2012 in the British team about optimizing the care of the athlete as the team physician. So this is our medical room, our treatment area in London 2012 for the British team. This is our physio treatment area. Here's a conditioning area where athletes would come in and do their stretching or some strength and conditioning or cardiovascular work. Here's Vicky in her GB kit. She was critical to the success of that team. Here she was doing urine testing, looking at specific gravity, looking for any signs of dehydration in athletes. And here she is distributing probiotic drinks to athletes. So we knew from the literature there was a suggestion that there was a reduction in salivary IgA with athletes in heavy training competition, which may lead them to susceptibility to upper respiratory tract infection. And we felt this was a simple thing to do, and we used a probiotic drink at this point, but you can use capsules as well. And each day a team leader would come in and take some of the probiotic drinks and distribute them amongst the team. We also had a leading expert interventional radiology, who provide us diagnostic ultrasound within our medical centre and provide ultrasound guided injections for athletes as required. We also had recovery area